Welcome back. Today we are looking at a little vial that is sitting in pretty much every ambulance and ER crash cart right now, tranexamic acid or TXA.
Yeah, TXA.
It's developed this reputation as the ultimate stop bleeding drug. But looking at the stack of research we have for this deep dive, that description feels, well, it feels a little dangerous.
It is. I mean, it's dangerous if you treat it like some sort of magic wand. TXA is incredibly useful, but it is absolutely not just see blood, give drug.
Right.
If you use it in the wrong patient or at the wrong time, you aren't just wasting money. You could actually hurt them.
So the mission for you listening to this deep dive is to figure out exactly where that line is. We need to unpack how this synthetic lysine analog actually works and review the heavy hitter trials, crash, woman, halt it, to see when it saves lives and when it actually causes harm, like clots or seizures.
Let's start with the mechanism then, because I think this is where the biggest misconception lies.
Yeah, I think most people just assume it is a procoagulant, like adding cement to a wall to make it thicker.
Right, but it's not. It's an antifibrinolytic.
An antifibrinolytic.
Exactly. So it doesn't build the wall. Instead, it stops the wrecking crew from knocking it down.
Okay, so the wrecking crew here is plasmin, right?
Yes, plasma.
The enzyme the body naturally produces to dissolve clots.
Exactly. See, when you bleed, your body forms a clot, but it also triggers a process to break that clot down so it doesn't block blood flow forever.
Which makes sense.
But in major trauma, that breakdown process goes into massive overdrive. TXA competitively inhibits plasminogen activation.
So it blocks the conversion to plasmin.
Right. It effectively furloughs the wrecking crew so the clot can survive long enough to stop the bleeding.
That makes perfect sense. It just stabilizes what is already there. So
Yeah.
looking at the scoreboard, the big win here is obviously trauma. The Cure-H2 trial from 2010 seems to be the one everyone cites.
Oh, CRA-SHOES-2 changed everything. It showed a significant decrease in mortality for general trauma patients.
And importantly, it did so without causing a spike in vascular occlusive events.
Right. No random heart attacks or strokes caused by clots, which was the really big fear at the time.
But there is a massive asterisk on that data. The clock.
The golden window,
Yeah.
3 hours. In CRASH 2 and later in the woman trial for childbirth, the data is very stark.
If you give TXA within 3 hours of the injury or birth, it saves lives.
But if you wait longer, the benefit just disappears completely.
And the woman trial, which focused on postpartum hemorrhage, basically mirrored the trauma results.
Yeah, it reduced death due to bleeding and did not increase clot risk. It solidified TXA as standard care for obstetrics.
Okay, so we have the body and the uterus covered. What about the brain? Because I am looking at CRASH 3, which focused on traumatic brain injury.
This is where the results get a bit messier.
How so?
Well, CRASH 3 showed it helped prevent death and mild to moderate head injuries, but for the very severe cases, patients with a Glasgow Coma Scale score of 3, meaning they're totally unresponsive, it offered no benefit.
So if the damage is too massive, the drug just can't compensate.
It seems so. But because it worked in trauma and obstetrics, the medical community naturally asked, well, why not the gut?
Right, like if someone has a stomach ulcer or a GI bleed, surely stabilizing the clot is a good thing.
Enter the HALT-I trial.
And this looks like where the winning streak ends.
It hit a brick wall. HALT-TT showed absolutely no benefit for GI bleeding. But even worse, it showed harm.
Harm? Like what kind of complications?
An increase in deep vein thrombosis and seizures.
Seizures, really?
It's a known risk with TXA. We saw it in cardiac surgery trials like ATAC-AS too. TXA can lower the seizure threshold, especially at higher doses. And this is exactly why the one-size-fits-all approach fails completely.
And that risk goes way up if your kidneys aren't working, right?
Significantly.
Yeah.
The drug is cleared by the kidneys.
So if a patient has high serum creatinine, indicating kidney trouble, and you give them the standard dose,
The drug just accumulates.
so that standard CRH protocol, the 1 gram IV bolus over 10 minutes, followed by a 1 gram IV infusion over 8 hours, that is not for everyone.
You have to adjust. The source material emphasizes reducing the dose based on creatinine levels to avoid that exact toxicity.
It really complicates the narrative for you as a listener trying to understand this. You have a drug that is an absolute lifesaver for a car crash victim or a new mother, but if you give that exact same molecule to a guy with a bleeding ulcer, you might give him a seizure.
Context is everything. It proved that timing and anatomy matter just as much as the chemistry itself.
Which leaves us with a really fascinating thought to end on. We always think of human blood as this universal system, but maybe our organs evolved completely different rules for how they handle clotting. What works for a torn uterine artery might be fundamentally rejected by the digestive tract.
Yeah, it is a great point to ponder.
Thanks for walking us through it. And for everyone listening, we will see you on the next deep dive.